Good afternoon, guys. Dr. Garcia. Now we're gonna get into the physical examination of your ankle and foot complex. I'm gonna go over, so similar to what we have done with the knee complex, you have your subjective examination, outcome measure tool, region-specific histological examination. All of those are gonna be included in your PowerPoint presentation for the differential diagnosis that we're recording tomorrow. And then lower quarter screening components. I did not mention this in the knee complex. With any lower kinetic chain, think about your hip, knee, ankle, and foot complex. Make sure you're screening your lumbar spine and SI joint to make sure that their pain is not originating from those segments above the kinetic chain. And at the same time, do screen those segments to make sure that you're not having double diagnosis or it's not a contributing factor for any of their ankle and foot disorder. So for the posture, I'm going to read everything that I have here in the handout so you can follow me. So you're going to want to watch the patient for any side-to-side asymmetry, any soft tissues differences, any differences in the bony landmarks on your shoulder, your cervical, thoracic, and lumbar spine, any issue with the hip and your glute region, to make sure that you're factoring that in the lower extremity of your patient. And since we're doing the ankle and foot complex, take note of the position of the ankle and foot relative to the knee complex. What you have on the list, I'm going to read the checklist that I have. I'm just going to concentrate on the ankle and foot for demonstration purposes because it's going to be redundant for you guys to be able to see that. So for the anterior view, while your patient is standing, I'm just looking at their head alignment, the shoulder height, the pelvic height, right and left side, and then rotation of the pelvis, either the right or left, and then your hip rotation. We've mentioned about your knee valgus and varus positioning already, and then your patellar orientation. So we're gonna have Matt here again on a standing position. So what I want to do is the same thing, hip width apart, okay, and just in a relaxed standing position. I'm looking for the orientation of his kneecap, which we have identified already when we did the knee complex. They're pretty symmetrical. I'm looking for the rotation of the tibia. So with him, I want to be able to see if the tibia is rotated internally or externally. So it just tells me if your leg is in or out. Okay. And then I'm looking at the same thing on your right side, if that's rotated in and out. I don't see any issue with that at all. I'm looking for the patient's resting position of the foot. Are they pronated or are they supinated? And then at some point, I'm gonna go here. I'm going to look at the height of the arches on both sides, and they're very symmetrical. So that's the one in your anterior view. So I'm going to go behind my patient here. So posteriorly, I'm looking for the head alignment. He's pretty symmetrical. I'm looking for the tilt right or left ear area. I'm looking for the height of his shoulder. They're pretty symmetrical. Any spinal curvature, I'm not going to make him take his shirt off because I know I don't see anything over the shirt. If that's the case, I'm just gonna ask my patient to take their shirt off and look for any scoliosis or any lateral shift deformity. He's not presenting with that right now, so I'm not gonna assess that. So I said height of the pelvis, hip rotation, and then the crease of the popliteus again, right and left. And then I'm gonna look for the calcaneus rotation. So with here, maybe you could just go this way so you could just capture that if you don't mind. I'm just looking for the orientation of the calcaneus on the left and then the right side. And then I'm looking for too many toe signs. So I'm looking for how many toes I could view at the back. So with him, I could see the last toe and half of the fourth toe, and that's normal. It's the same thing here. I'm looking for the last toe and then half. So let's make Matt do it. Can you rotate your left foot out this way? A little more? Actually, less. So if that's the case, that's going to be a too many toes sign wherein I could see more toes on the left side as compared to the right side. And then last but not least, what I have in your handout on the lateral view, just looking for the head alignment, spinal curvature again, pelvic height, hip flexion, and then knee flexion and refer. So the next one, we're going to make Matt walk for the gait analysis. I'm going to be looking for if at any point, if there's any pain in your ankle and foot or knee while we're watching you with the walking, please let me know. I'm gonna watch with two views, front and back. So what I'm going to do first, you're gonna walk forward twice. All right. Regular speed. Any issue with that?
No.
And then this way again, please. Very good. And then stop right there. You're gonna walk backwards. Any problem with that?
No?
And then turn around. You're gonna walk one more backwards. Very good. And then I'm gonna want you to stand on your toes.
Okay.
And you're gonna walk forward. So I'm looking for stability to be able to keep the heel off the floor. Are they symmetrical? And the same thing, walk this way. And you could watch that sideways as well, eye level, of course. And then I'm gonna want you to stand in your heels now for the next one. Walk in your heels, so I'm looking for the dorsiflexors. And the same thing, I'm looking for the height that the toes are clearing the floor. And the same thing, walk that way. And then if it's possible, if it's too much of a pain for you, can you try to walk on the inside of your foot? Be careful with this. If you have a sprain in the medial side, I will not do this test. And then last but not least, I'm not gonna do it with him. You can ask your patient to walk outside, okay? And that's good. Perfect. I don't want to sprain my patient, that will be bad. So take a sit right here. How old is your shoes? The one that you're wearing right now?
Years?
Okay, do you remember when you purchased them?
Like probably 4 years ago.
Okay. Can you just take off one for me?
Yeah.
I'm gonna check the bottom. So the way you're gonna be looking at it, what do you use this shoe for? Workout, walking, going to work?
Walking?
Okay, going to the gym, when you work out at the gym, no?
No.
So you could look at the flexibility of the shoe as well. You can bend them. If it's supportive, if it's rigid, it's not giving you enough support for your patient. So that's probably what he likes is for walking. And then you just want to see the bottom portion, just make sure that's got some traction. So that's one of the things you have to advise your patient. If it's not creating support for them with their day-to-day activities, that might need to change the shoe. You just leave it on.
Okay.
You're welcome. And then on the list of your functional testing, I'm not going to demonstrate them because we did the sit-to-stand transfer. We did the squats mechanics already with the knee examination. We did your forward lunge and backward lunge. We did the step up and step down. We did it forward and back and then sideways. We did the single leg stance with him before. And then we did the walking and running already, the one that you can assess at the gym. So we don't need to do that. And then the last thing that I have in the list, I'm not gonna make him do that. You could just assess your face's ability to be able to go up and down the stairs. And you have no issue with that, correct?
No.
So I'm watching my pace's ability to be able to do it reciprocally or one at a time if they have some issue with their leg. The biomechanical evaluation, that's gonna be under your differential diagnosis. I'm gonna upload a video on that. So you have your Feist line, subtalar neutral, and then your navicular drop. So I just put that on the handout so you can follow me. But as I said, that's gonna be your differential diagnosis. So next we're gonna have you sit right here
Okay.
with your socks and shoes off. I'll be laying down, it's better so you'll be more relaxed, if that's okay.
On my back?
Mm-hmm. So I'm just gonna keep my hand out here because if I don't look at it on my list, I'm gonna be forgetting it. So first things first, similar to what we have done before with your knee joint complex, I'm gonna use the dorsum of my hand. Have you ever had any pain in your ankle and foot?
No.
No surgery before, yeah? That you have remembered?
No.
Have you ever sprained your ankle before?
Surely, at some point.
Do you remember the mechanism of the injury by any chance?
No.
Do you like to run?
I don't mind it.
And that's not an issue for you right now when you run?
No.
Perfect. And then you said you like skiing, correct?
Yes.
And that's not an issue with the ankle and foot when you do that? Okay,
No.
good. So I'm just gonna start laying my hand to see if there's any side to side temperature difference. And then at the bottom. So with here, I'm gonna start with the big toe. I'm just looking for some callus formation. They're very symmetrical, so I'm not gonna be worried about that. And then you could do your pulse assessment. You have a small pulse right here. I'm just gonna be feeling for that. Good pulse. I could just count 10 and compare that on the side. And then you're looking for your bunions, hallux valgus, if your first MTP joint is affected, if it's in valgus position. I'm palpating for the joint line too, for the first MTP joint. So you could just palpate that. And then you could look at the deformity. So I said this is gonna be in your differential diagnosis. You have your closed toe deformity, hammer toe deformity, and then your mallet toe deformity. But I'm gonna demonstrate a figure of 8 right now while I'm here so you guys can see it for swelling. I'm just gonna be assessing the degree of swelling if you have anything. I'm pretty sure you're not gonna have anything. So you have a few landmarks here: medial malleolus, lateral malleolus, medial malleolus, and then lateral malleolus right there. And then navicular tuberosity, and then the fifth metatarsal, navicular tuberosity, and then the fifth met. So I'm gonna start with the right side. I'm just gonna come under. Start on the lateral. Actually, I'm gonna start in the medial, so I can just cross over. It's easier. And then come on the fifth met. And then navicular tuberosity. And then you're gonna end with the same thing. So with here I have 67. So the same thing here. I'm gonna start immediately. Sorry. So this is lateral here. I'm just gonna come over. Navicular tuberosity and back. And well, it's 68 on both sides, so they're symmetrical.
Great.
So expect if you have a swelling, you're gonna have more side-to-side difference of those two. I'm not gonna go over the sensory testing. We've done this already in class. So the next one, I'm gonna get into your active range of motion over pressure. But before that, I'm just gonna wash my hands. So just pause. Okay, next guys, we're gonna get into your active range of motion over pressure. So we have your ankle dorsiflexion, plantar flexion, your inversion and eversion, and then we're gonna show you how to perform the passive range of motion as well. So I'm gonna do the active range of motion 2 ways. In supine position while he's laying on his back, and then in prone position. So let's do this in supine position. I'm gonna bend your knee
Okay.
and support it here. So what I want you to do, I want you to bring your foot towards your head, that way. And then relax, one more. And then keep it there, and then over pressure. And just make sure you know your goniometric landmarks for that if you need to measure them. And then the same thing on the other side. I'm just gonna keep your knee bent. And then the same thing, bring your foot towards your head and relax. And then one more. Just make sure I level them so you can see if there's any deviation. Any problem with that?
No.
Okay, good. And then I'm gonna keep it here. You're gonna bring your foot towards the door and then relax. And one more. And it's pretty good. So I forgot to mention, let's go back to the dorsiflexion again. So bring your foot towards. So I'm just stabilizing the distal leg and supporting it. My overpressure is on the metatarsal. And then plantar flexion, you're gonna bring it down and neutral. And then one more. Overpressure is on the dorsum of the foot, and you can even move your calcaneus in this manner. No problem?
No.
And let's do that on the other side. So the same thing. Bring your foot down, and then back. One more. And then overpressure. So dorsum. So if you guys could appreciate that, this is doing it in calcaneus. I'm just doing that fulcrum mechanics. We're gonna do the same thing with the inversion and eversion. So with this, you're gonna bring your big toe towards that window and relax. One more. Very good. So with this, I'm just keep it there for us, Matt. I'm gonna move the calcaneus this way and then move it with the fifth toe towards the window. And then the same thing here. Bring your big toe that way and then relax. Big toe that way. So as you can see, I'm supporting and I'm pushing. So calcaneus goes this way and the fifth toe goes that way. And then eversion, you're gonna bring your big small toe this way. Yep. And then one more. So it's the opposite. Calcaneus moves medially, and then just bring the big toe laterally. And then the same thing here. Little toe that way. Perfect. And then one more. And then the same thing, and just bring the calcaneus that way. And big toe this direction. You could do them in a knee extended position as well. So let's just do that. I'm just gonna do one rep for the sake of time. Can you bring your foot towards your head? Sorry, just this way. Just the foot, yep. So over pressure, there's the same thing. I'm just gonna do one rep. I'm just gonna do a demonstration. Pretend this is the third repetition. That way, towards me. That way. For inversion, big toe that way. Nothing changes. That way. And then for eversion, that way. So I'm gonna do the same thing here so you could see it. Bring your foot up, over pressure, that way. Plantar aspect and calcaneus towards me. And then plantar flexion, foot towards the door, that way. And then inversion, big toe, that way. No problem. And then eversion that way. It's weird, yeah, with the movement. We're just isolating your foot right now. And then the prone position, I'm gonna do one rep. You're gonna go face down.
Okay.
If you feel like you can get a better mechanics, I'm just gonna do one foot here. So this is, sometimes I like to do this in the clinic because I could really maneuver the foot. So now you're gonna bring your foot towards the ceiling. Right, that way. So that's plantar flexion. Go ahead, up. Over pressure, calcaneus, and the dorsal of the foot. And then dorsiflexion, you're just gonna do one rep. You're gonna bring your foot down towards the table. That way. And then inversion, big toe towards that door. Over pressure this way. And then eversion, over pressure that way. Good? Now you're gonna lay on your back again, if you don't mind. We're gonna do passive movement. So I'm gonna, let me do all the work for you. Okay, just relax. I'm gonna do it with a knee flex position again. Come closer to me if you can, please. Perfect. So we're just gonna do dorsiflexion passively. Plantar flexion, no problem. Inversion, and then eversion. So the same thing I would do the other side with a knee flex position. Come this way if you don't mind. Towards me, thank you. I'm gonna do, let me do all the movement for you, no problem?
No.
And then this way, no problem?
No.
And then in, and then out, no problem? Good.
Perfect.
So I could do the same thing in this position. Let me do all the work. Dorsiflexion, plantar flexion, and I can even grab the calcaneus. Inversion, and then eversion. I'm not gonna do the side, you guys will get the idea of how to do that. In your handout, you have the isolation. You could do your metatarsal, your subtalar and talocrural joint. So if I'm doing the metatarsal joint, I would just do extension and then flexion. Any problem with that?
No.
Extension and then flexion. So I'm isolating, I'm stabilizing the tarsal bones, and then I'm just moving the metatarsal bones. Took me a second to do that. Tarsal bones, and I'm moving the metatarsal bones. So you could do that flexion and extension. You could do a subtalar joint, either isolating the distal tibia and the fibula. Let me move it for you. I'm just gonna move them in and then move them out. So I have an appreciation if I move his subtalar joint internally towards you guys, I might be able to reproduce a patient with an ankle sprain, lateral side. And then if I move it this way, you might have an ankle sprain on the deltoid ligament. And then last but not least, you could isolate your talocrural joint, and we did that before. So resisted muscle test, I'm not gonna demonstrate that because we did that with the knee physical examination already. The only thing that I'm gonna demonstrate on the muscle length
you guys have done the gastrocnemius already. Knee extended position. Measure the degree of dorsiflexion. Soleus, the same thing. Dorsiflex. Measure the degree of ankle dorsiflexion. And then the difference with this, with the plantar fascia, you're gonna keep it there. I'm gonna be matching all the toes of my patient. So you're gonna keep the knee flex position. I'm gonna dorsiflex. I'm gonna be supporting my patient in this way. And I'm gonna be matching everything, and that should create that plantar fascia stretching. And the same thing, the way you're gonna be measuring it, 8-second person will be placing their goni. Sorry. This way. So while I'm doing that, so pretend somebody's holding it. The same measurement. So fulcrum and the medial malleolus, first metatarsal bone, and then distal tibia. So those are good. Okay, next one, we're gonna get into your joint mobility testing again. As a quick review, for any joint mobility testing, our main goal is to be able to reproduce your patient's familiar sign or comparable sign. So whatever is familiar with them that they came into the clinical setting, I want to be able to reproduce that. So for example, if Matt walked into the clinic with an ankle inversion sprain on the outside of his right foot, that's my whole goal when I'm performing it. I'm looking for normal mobility on the affected and unaffected side. That means, are they moving the same? I'm looking for hypermobility wherein the affected side is not moving a whole lot as compared to the non-involved side. And then last but not least, the hypermobility spectrum wherein the affected side is moving a whole lot as compared to the other side. So I like to be able to assess in the clinical setting, typically you see a not affected side, because that will give me a perspective or benchmark on what a normal joint feels like. But for this demonstration purposes, I'm going to start with the right side first. So I'm going to start with the, what I have on the handout, you have your proximal tib fib joint. We did that demonstration already with the physical examination of the knee. So you have your anterior glide, posterior glide, superior glide, and inferior glide. So the way you're going to be doing that, so if I'm assessing this side of my patient's leg, I know we mentioned before in my demonstration with the knee examination, think about your patient's ability to be able to move the knee joint complex with functional tasks or movement at the gym. And at the same time, that's really impacting your patient's ankle ability to be able to perform high level activities. Even the basic walking and running, that joint could be impacted. So I'm going to skip that in the demo. The next on your list is the talocalcaneal joint, or your subtalar joint. So your loose back position is midway between the range of motion. So let's do the lateral glide first, or reversion glide. So the patient is going to be in a side lying position. You're going to lay on your right side this way. I'm going to use a pillow here between your knee for comfort. I'm actually going to be testing this leg. So come down a smidge. I want this foot hanging at the edge of the table. Perfect. And then this knee could be in the bent position. Are you comfortable?
Sure.
He's pretty good here. I don't want my patient turning that way or this way, so make sure it's well supported. So if I want to do a lateral glide of the subtalar joint on this side, I'm going to want to put a towel here. And then with everything that we have to do, you're going to have to do a distraction force. So do an AP stance, stabilize your distal tibia and your fibula. And then at the same time, grab the calcaneus and then just glide them laterally. So not a lot of movement there. So again, for your lateral glide, you're gonna stabilize your tibia, your fibula, and then your talus bone. Grip them in a C manner. I like the C grip. Palpate for the joint line and then just glide them in this direction. If I want to do a medial glide so I don't have to reposition him, I'm going to do the top leg right here. So can we just bend this bottom knee all the way there for support and then extend this? Yep, perfect. So relax them. So when you guys perform this one another, the same exact thing. Palpate for the lateral malleolus, medial malleolus, and then the talus bone. And then just grip them and glide them in the medial direction. So the same thing, I did a traction force and that's your medial glide. So that's your joint line right there. Next on the list, you're gonna be face down. P2A in the calcaneus, so I'm just gonna be bending this knee. So web space of my right hand, watch my elbow line up here. That's your stabilization. I'm on the talus bone. Web space on the left hand is gonna be in the calcaneus bone. Wider base of support. I'm just pushing that direction towards the door. So that's your P2A. And then if I wanna do a distraction force, technically I could lower the table, but I'm gonna make it happen here because that's what we do. We adjust depending on what we have in the clinic. You just distract them towards the ceiling. So what I'm doing here with the distraction, I'm just grabbing my calcaneus towards the ceiling. And if you want to get into the talus bone too, you should be able to do that. Okay? And then last but not least, the longitudinal one, you're gonna distract your talocrural and subtalar joint. You're gonna go on your back. And this is gonna feel good for a lot of the patients that have some hypermobility deficit. Grab the calcaneus with my right hand, talus bone on my left, and I'm just distracting this way. Any problem with that?
No.
And then the same thing here. Right there. So the difference with that, I'm grabbing the subtalar joint and then the talocrural joint as well for distraction force. So next, we're gonna do the talocrural joint, the loose back position. You have your midway between inversion and eversion, and then a slight plantar flexion in the foot, so it's already there. You can put a towel under here too. And then I'm gonna start with the posterior glide because that's what's easier. So with the talocrural joint, you're gonna stabilize your medial and lateral malleolus. And then, see the line of force here, I'm gonna use a pen so you guys can see it. So this is my traction force on the talus bone, and then I'm just driving that direction. So if I want to put a pen on my mobilizing hand, on the right hand, it goes that direction. You can go under too. Some therapists prefer it this way. I like it on top. So whatever is easier for your grip when you practice, this is easier for me. As you can see, I have to side bend my trunk this way because I have to follow my line of force. If you do this in a practical or competency, that's going to be off with your positioning. So side bend and drive that direction. So that's your posterior glide of the talocrural joint. Ankle OA patients, hypermobility deficits, you're going to have an issue with that. So the same thing here on the left, just traction. And then posterior glide. Anterior glide, you're going to be face down, please. So you're going to do the same thing. Loose back position, just like dorsiflexion. So make sure you're cushioning your patient's foot a smidge towards me, Matt, if you can. Move. Yep, perfect. So the same thing, just grab, so calcaneus and over to the talus bone. Grab the distal medial and lateral malleolus, so distal tibia and your fibula. Traction force, similar to what I have done before, and you're gonna push your talus bone anteriorly. That's why this towel is gonna be a good positioning, because it cushions the dorsal of the foot. So the same thing here. Grab the medial and lateral malleolus. There's my joint line. Traction, and that way. Next on your list is your distal fib joint, loose back position. It's a slight plantar flexion. We're already in that position. So I'm gonna start with the anterior glide because it's already in prone position. So the way you're gonna be doing this, you're gonna be stabilizing your distal tibia or your medial malleolus. So I'm gonna come under with 4 of my hand right here. And then my wedge place on the right hand, just relax. It's just pushing anteriorly. So this your distal tib fib, syndesmosis. I'm just stabilizing my distal tibia, and I'm just pushing my fibula anteriorly. And then the same thing here. Just relax. The same point of stabilization. Cup with your 4 fingers in the distal tibia. Come over the lateral malleolus and then push anteriorly. And then on your back, it's the posterior glide. So the same thing, come under with a towel, stabilize here. I have my web space under, and I'm just pushing you down. Any problem with that?
No.
You're falling asleep?
Maybe.
And then this way, posteriorly. So really just the web space, and the same thing, if I have a drippy nose, it should fall on the ankle joint of your patient. I hope that's not gonna happen in the clinic, that would be bad, but it's just a line of force reference.
Rona.
So next one, we're gonna get into your MTP joint. Loose back position is gonna be 10 degrees, a slight extension. So the way I'm gonna be doing this, I just need a cheat sheet here because I'm gonna forget what I'm doing. So you have your dorsal glide, plantar glide, you have your medial glide, lateral glide, and then medial and lateral rotation. So you're gonna I'm gonna use the first MTP joint to be easier for demonstration purposes. So the way you're gonna be palpating for the joint line is right here. So stabilize with a pincer grip with your first metatarsal bone, and I'm gonna be mobilizing with my proximal phalanx bone. So think about your patient with gout arthritis, think about your patient with difficulty with terminal stance extension, because we need 60 degrees of hyperextension for this. So you might have some issue with that. So I'm just gonna check this big toe, okay? So stabilize closer to the joint line, AP stance again. So I'm gonna come on top, and I'm just moving my proximal phalanx towards that direction. That's your plantar glide. Towards this direction, that's your dorsal. So let me line up a pen. Plantar glide. Follow the axis because you're gonna be in a slight extension of the big toe. And then dorsal glide is gonna be this way. Medial glide is gonna go that direction towards the big toe. Lateral glide is gonna go towards the small toe. So the same thing, just gonna move this way for your medial glide, and then lateral glide in this direction. Internal rotation, traction, rotate them internally. So I'm turning my body, so you're going in that axis. And then external rotation, I'm going in this axis, I'm rotating away from it. And this way. Nothing changes with your IP joints. If I want to do the big toe, all I'm gonna do is just come down with the proximal to the middle phalanx. So dorsal glide, so it's going this direction again. Plantar glide, this direction. Medial glide, this direction. Lateral glide, this direction. So medial, lateral glide towards me, rotate, and then external rotate. And then what you have on the list, you have your first ray and your fifth ray. So I'm gonna demonstrate that in a sec. You could do similar to the hand. You could do this. It's like a quick separation. And then the other way around. But if I want to separate my first ray, I'm just gonna come half kneeling position. 4 of your fingers are gonna be stabilizing all the metatarsals, 2nd to 5th. Web space, I'm just moving this direction with the first ray. Dorsally, and then plantarly if I wanna grab it that direction. And then the 5th ray I'm gonna demonstrate here is gonna be a reverse. Stabilize the 1st to 4th metatarsal bone. I'm gonna go this way, and then this way. Patient, you have a question?
No, sir.
All done. Thank you.